Hello everyone, good morning. Good morning to the first PHARMAC session. So for PHARMAC and for Friday. Good morning everyone. Yes, so I hope all of you have read. All of you have read your pharmacokinetics. Very good. Okay, now bete how to study PHARMAC. First of all, let us just talk for 5 minutes on how to study PHARMAC. See, pharmac is one subject which troubles a lot, but it is very scoring. It is extremely scoring, right? It is troublesome because it is vast and it has a lot of drugs, a lot of mechanism of action, lot of side effects. But at the same time, it is very scoring. So if we divide pharmac into every Friday one topic, we will be able to complete pharmac over a period of months, right? You cannot cover your pharmac and your medicine in just one go. You cannot do that. It is impossible, even for the medical people, even for anybody, even for those who are preparing for a super specialty. Pharmacology and the medicine part cannot be done in one go in 1 week, right? That is why I have divided it on every Friday. We are going to deal with some portion of pharmacology, and in that you become perfect. Move forward again, next topic, become perfect. Now, before every other Friday, like this Friday, I am doing pharmacokinetics. Next Friday, just read pharmacokinetics and read pharmacodynamics. Pharmacokinetics को revise करो, dynamics को भी learn करके आओ. Right? So that way, every single Friday, you need to revise what has been done on the previous Fridays and learn what is required for your new Friday. Right? This way, pharmacology will come into a cycle. And revision will be just a piece of cake for you. Right? Now, revision can be questions, revision can be theory, revision can be anything that you find is good. Okay, so chalo, let us start. First of all, what is pharmacokinetics? Kinetics means, see, there are two terms, pharmacokinetics and dynamics. So how do I learn it? The dynamics, the drug on body. So action of drug on body, the drug on body is the dynamics. Action of body on drug. What does the body does to the drug? How does it break? How does it excrete it? How does excretion happen? The metabolism happen? What does the body do to the drug? Okay. Now with this information, let us start with the questions. And eventually we'll keep on doing all the theory as well. Question number 1. Yes, everyone? All are false about the route of drug administration except. So, beta, route of drug administration is another important thing. First, let us do the concept and then you do this question. Okay, then you do this question. The concept is, okay, see beta. In this, we know the routes of administration can be enteral. Enteral means which is not going directly by an injection. Oral, sublingual, rectal, they are enteral, oral. Parenteral means intravenous, what is going into the body, into the blood. Right? Topical and inhalational. Inhalational is a very quick way of action. IV is again a very quick way. IM, subcutaneous, they are quick way of action. That is why we use that in the emergency. In anaphylaxis, we are giving subcutaneous adrenaline, IM adrenaline. Right? Now, bioavailability. What is bioavailability? I will tell you. But first, bioavailability is maximum 100% for intravenous. Whatever you give intravenously, bioavailability is 100%. Oral is less. Why? Because oral में क्या होता है? It passes through all the metabolism. It passes through the liver and everything. Right? Now, this particular diagram is again very important. Just a quick revision. You have to know the various angulations. So, intramuscular injection is given 90 degree. Subcutaneous is given 45 degree, intravenous 25 degree, and intradermal can be given 0 to 10 or 10 to 15, 0 to 10 degrees. And you must know intradermal is given just over the epidermis. Intravenous goes into the vein, and subcutaneous goes into the subcutaneous tissue, 45 degree. IM has to be deep. The needle has to be big for IM. If any one of you has seen the insulin syringe, then you know it has a very small needle. Very small needle. The subcutaneous has to go only till the subcutaneous and not to the muscle. Right? That is why it is at 45 degree, and the needle for that is very small. Okay, IM is 90 degree angle. अर्जुन बेटे आई हाँ ये भी सही है डॉक्टर अर्जुन. सी इट कैन बी नियर. दे आर नॉट गोइंग टू आस्क यू द करेक्ट angulations. They are not going to give you a choice between 45 and 40, right? So this diagram, it can come to you. They can give you the syringes and they can ask you what has to be done, right? Again, please see the hand posturing. Intramuscular 90, subcutaneous 45, intravenous 25, 30, intradermal almost zero. Almost zero, right everyone? So this is this. Okay, next is what is bioavailability? Let us revise few concepts and then we will move forward. Okay, what is bioavailability? Bioavailability is the fraction of the drug which reaches the systemic circulation. Right. So please remember, bioavailability is the drug that is reaching the circulation. Very, very, very important concept. And now with this information, let us do the questions. Yes, tell me the first question, everyone. Tell me the first question. What should be first? All are false. Please read the question carefully. All are false. All are false except about the root. So 80% bioavailability is false. IM administration is sterile technique. This is true. See beta, IV and IM both need a sterile technique. Therefore, you cannot just give it like that. You need to have experienced nurses. ID injection produces local necrosis and irritation. False. Inhalation produces delayed. No, inhalation is very quick. That is why, beta, when somebody is having an attack of asthma, what do we give him or her? We give salbutamol, we give inhalation. So inhalation causes quick availability. Lung say it comes as a quick availability. So please read the question carefully. This is also false. So answer becomes 2. Please read the line very carefully. Otherwise, the known concept will be done wrong in the paper. And what will happen if the wrong, you know the concept, still you do a question wrong? You lose marks, right? Okay, next. Volume of distribution of drugs is altered in which of the following conditions? Okay. Now, beta, this I want to do personally with you. What is volume of distribution? What is volume of distribution? Can anybody tell me what is volume of distribution? See, beta, local tissue irritation can occur because of any injection, subcutaneous also, ID also, any injection, majorly subcutaneous, because when we give insulin subcutaneously, it may lead to a local, lipodystrophy. No, doctor, I don't want, Dr. Uma, मुझे वो नहीं चाहिए. Volume of distribution is just the distribution in the tissues. Correct. Now, tissues may, if, see beta, the drug can go into the tissue and it can be plasma protein bound. right? Any drug which is bound to the proteins will never go to the tissue. Is this point clear? See, a drug has two choice. Either it can bound to the plasma protein or it can go to the tissues. If a drug has more plasma protein binding, it will not go to the tissues. Correct? This is clear, very clear. Now let us look at all the options one by one. See, in obesity, more fat is there, so more volume, more distribution is there. Athletes, not altered. In a pregnancy, again, what happens? Blood volume increases, due to which what will happen? The distribution may alter. Old age also, volume of distribution increases because plasma protein binding decreases. Right? So old age, obesity, and pregnancy, and even in the neonates, infants. Right? So this question I have put so that you can know that in conditions like obesity, pregnancy, because proteins are being altered, blood volume is being altered, old age also and infant also, they are similar, right? In physiology, old age and infancy are almost similar, but with few differences, right? So in old age, neonate, obesity, pregnancy, in all of these conditions, volume of distribution can be altered. Okay. Question number 3 is very important. Very, very, very important. Now, what is the mnemonic for prodrugs? What are prodrugs, everyone? Prodrugs are which are given and they convert into something. Right? So, what is the mnemonic for prodrug? Let us first see this. Okay, please everyone pay attention. Prodrugs. Prodrugs, the mnemonic is all prefer clinical MDS, right? All of you want to do MDS in clinical branches. So all prefer doing MDS in clinical. That is the mnemonic for prodrugs. Prodrugs, all ACE inhibitors. This has to be on your tips, everyone. All ACE inhibitors except captopril, lisinopril. P for prednisolone, and your PPIs, very important, proton pump inhibitors. D for dipivefrin. See, beta, dipivefrin, sometimes it may come into the question. So please learn everything that I'm teaching you. That is important. Okay, whatever is not important, I will tell you, don't do it. M for methyl dopa, M for 6-mercaptopurine, and minoxidil. Each and every drug has come as a question. Da levodopa. S for sulfasalazine and Salindec, and C for clopidogrel carbimazole. Every drug has come as a question. Clopidogrel has come n number of times. ACE inhibitors and except captopril, lisinopril has come n number of times. Right? So this mnemonic should be on your tips. Prodrugs, what are the prodrugs? It should be on your tips. Now, beta, before I move forward, I want to do certain important concepts of pharmacokinetics. Then we will do the questions, with quite a speed. Now, you all know any drug is absorbed in ionized form or non-ionized form. If there is a drug, please tell me, because you have already read pharmacokinetics, please tell me any drug is absorbed in ionized form or non-ionized form. Yes, unionized, non-ionized, whatever form, correct? So beta, with this information, please remember this is a rule. The non-ionized drug is absorbed and the ionized form is not absorbed. Right? Now let us play a quiz-like thing. If there is a drug which is acidic in acidic medium, it is going to be more non-ionized. it is going to cross the barrier. It is going to be lipid soluble. But if a drug is acidic in basic medium, they will react. Once they react, ionization will happen, ionized form will increase. And when this will happen, crossover will not happen, it will be water soluble. Right? And same applies for the basic and basic medium, basic drug in acidic medium. I hope this chart is clear to you. Yes, everyone. I hope this chart is very much clear to you. Yes or no? It is very important. Directly, a question will come. There is a drug which is acidic. Right? Okay, then let me give you one question then. There is a drug with pKa6. pKa means nature of drug. Nature of drug. And I put it in a medium of pH 3. Which form will be more? Will it be lipid soluble or will it be water soluble? Please tell me better quickly what it will be. Water soluble or let us see if you can answer this question. And will it be able to cross over? Will it be able to cross over? Yes. Yes, it can cross. Right? Next, beta, next very important things about bioavailability, which you should know. And I'm just giving you a gist so that we can all do all the questions together. Bioavailability, please remember, if it is high, if a drug has high bioavailability, it is available more, right? That means I will require low dose of it. If it is less, I will require high dose of that drug. Right? If a drug is more absorbed, simple, just apply logic. If I can absorb more drug, the bioavailability is going to be more. And vice versa, simple. Right? Next, if a drug undergoes high first pass metabolism, that means it is destroyed more in the liver. First pass metabolism means it is going to the liver, getting destroyed. So if it is destroyed, obviously in my body, in my blood, on my target organ, the drug is going to be less. So decrease bioavailability. Anyone having any problem in these three concepts, please raise your hand. And obviously the opposite is true. Decrease first pass metabolism means the drug is not being broken. I have more bioavailability. That is why beta IV drugs, they bypass the liver. They do not go to the liver. Right? That is why they are not having first pass metabolism. They don't go, and therefore their bioavailability is 100%. Okay. PKA hota hai beta. PK is like your nature. Like what is your nature, Dr. Sara? Are you a quiet person? Are you a loud person? Are you are you an extrovert, introvert? So nature, the nature of a drug is 6. We know 7 is medium, neutral, right? So below 7 is acidic. So the nature of the drug is acidic. If I put it in the acidic pH, then I'm going to have more of unionized form. Okay, Dr. Vaishnavi, chart I will explain to you in the end. Please stay back, right? If majority has understood the chart and you already know the chart, because in PAATHSHALA beta, you have to come a little bit, you have to come a little bit oriented about the chapter, right? So in the end, I will explain the chart wholly, right? Because majority, if they have understood, then we can move forward, and I will, Dr. Vaishnavi, explain it to you in the end when everybody is gone, so that time cannot be wasted. Okay, Now, acidic drug, I have put in acid medium. 3 is also acidic. So I'm going to have more of unionized form. More of unionized form is going to be lipid soluble and it is going to cross. Correct? So till here, everyone, have you understood? Can I move forward? Can we do more questions? Right? Now here, beta, please remember NTG, nitroglycerin, has high first pass metabolism. Therefore, it has got high first pass metabolism. Therefore, I do not give it orally. I do not give it orally. In any cases, I give sublingually. If somebody is having a problem, having chest tightness, chest pain, then I give it sublingually. And this has many uses. One, it is super quick. Second, the effect has come. The heart rate normalized, palpitations decreased. I can spit the remaining one. So the remaining drug can be spit out so that toxicity can be avoided. Right? So, and third, it doesn't require anybody else to come and give you the drug. You can keep the drug in your pocket and beta, you can take it yourself. Now, having said that, I want each one of you to tell to your parents and even to your colleagues, even to yourself, you always have to keep 3 drugs in your pocket. I carry it, Dr. Amit carries it. I keep it everywhere. I tell it to anyone and everyone I meet, right? Because post-COVID, heart attacks have increased. And 3 drugs just, I think it's the whole thing is going to cost 30-20 rupees, but it is life-saving. Life-saving, right? Now, I want all of you to keep Disprin with you always, right? And tell your parents also, tell your relatives also. Nitroglycerin and clopidogrel, antiplatelet drug. Now suppose there is a person you see on the road and he is tightly holding his chest, then beta 2 tablets of Disprin have to be given immediately. That is the maximum. 2 is the maximum. Right, 2 is the maximum. If is agar aapko lag raha hai it's a total heart attack with palpitations, ash gray face, and the patient, then 2 tablets of Disprin have to be given. You know, just by giving 2 tablets of Disprin, you give that person 2 to 3 hours of life. Right, in any heart attack, in any stroke, until and unless it is a hypertensive stroke. Hypertensive stroke may we tend to do bad if we give aspirin, Disprin. Right, then if it is a known patient ke usko rehta hai, arrhythmia is always there, nitroglycerin should be kept, but this is the last drug to be taken. This is not the first drug. First drug is aspirin, Disprin. Again, if the patient is very old, then he needs to take antiplatelet as well. So always keep these 3 drugs. You can, save at least 1 life in your lifetime. This has to be there in each and everybody's pocket. Parents especially, and even your older siblings, anybody is now prone for a heart attack post COVID. Okay, so this is all about bioavailability. Another question about bioavailability, there is a curve, plasma concentration and time curve. When I get this curve, area under the curve, AUC, tells me about bioavailability. Correct? Bioavailability. Now, who will tell me what is bioequivalence? What is bioequivalence? I cannot give one drug of 2 different manufacturers. Normally, you take the paracetamol of one company, you take the paracetamol of other company, doesn't make a difference. Right? Why? Because their bioequivalence is same. Not with phenytoin. Phenytoin, dilantin, when you give of 2 different companies, their dosages need to be altered because one company and another company doesn't match. Correct? Okay. Now let us see the questions again. Okay, please tell me question number 3, everyone. I have given you, I have taught you. Correct. Correct, Dr. Simran Akansha. Very good. Right? But the problem here is phenytoin, I cannot have the same bioavailability with two brands. So I need to, if suppose a patient is taking brand A, I need to give him brand A for the rest of his life. Okay. Question number 3. Question number 3. What should be 3, everyone? Correct. Tipivarine, enalapril. Correct. So all prefer doing MDS in clinical. Prodrug is a very important concept. If you forget it, beta, it's going to be problematic. Okay, question number 4. First pass metabolism. Okay, this I will tell you. See beta, lignocaine first pass metabolism is very high in LPG drugs. LPG, lignocaine, propranolol, and for G is nitroglycerin NTG. Right? So here lignocaine, propranolol, and one more drug which you can learn here is salbutamol. So please learn first pass metabolism is very high in LPG drugs. LPG drugs. Okay, here only let us do a concept of again absorption. We all know there are drugs which are acidic and there are drugs which are basic in nature. Now, as I told you, acidic drugs will be more absorbed in the acidic environment, right? In stomach, they are absorbed more. Basic will be absorbed more in the basic environment. And where do I have the basic? I have taught you in the GIT, right? When we did the GIT PAATHSHALA, I have taught you intestine has basic. Now, why? Because pancreatic choose the most basic content is coming. Now, in the intestine, most basic drugs are absorbed, should be absorbed, right? This is our common sense. This is what we know, we derive from the formula. But beta, majority of the drugs are absorbed in the intestine, chahe acidic or basic. Why? Because intestine mein the time is more and the surface area of the intestine is more. So yes, acidity, basicity determines what will happen to the drug absorption. But the time, the surface area determines that all drugs are absorbed in the intestine. Correct? If they ask you acidic drugs should be absorbed more in stomach, basic drugs should be more absorbed in intestine. But both practically, if we see, all the drugs are absorbed in the intestine. Correct? Next, the bioavailability connection with the dose, with absorption, with first pass metabolism, anything can come. So bioavailability is very important. Next, everyone, reactions. Yes, question number 5. Can you all do? Question number 5, everyone. Phase 1 and phase 2 reactions. See beta, let us revise the concept here only. Phase 1 and phase 2. Phase 1 reaction are mostly catabolic. They are catabolic. What do I mean by that? Okay. Phase 1 and phase 2. Phase 2 reactions and phase 1 reactions, they are phase 1 is catabolic, phase 2 is anabolic. करेक्ट. फेज 1 में मोस्टली क्या आता है? ऑक्सीडेशन, हाइड्रोलिसिस, रिडक्शन, cyclization, all of this comes, right? Should I write or you know it? Oxidation, cyclization, reduction, deamination, all the breaking wala reaction. In phase 2 we have all the joining wala, like glucuronide conjugation, acetylation, methylation, anything which is being joined. Now, phase 1 reaction occurs so that the functional group is exposed. And phase 2 metabolic reactions occur so that the drug becomes water soluble. And if a drug is water soluble, it can be excreted. Right? So, beta, now the phase 2 reactions are 5. Yes, many people have answered B, C, and D. See, anything which is to be added, deamination, dealkylation, breaking हो रहा है. So just remember, phase 1 में you break. The body is very angry. Why has the drug come into my body? So what will the body do? It will break all the added or anything which is oxidation, reduction, anything, it will break. In anabolic phase 2, it will add. Glucuronide conjugation is the most common phase 2. Oxidation is the most common phase 1. Correct, everyone? And most of the phase 1 reaction plus the glucuronide conjugation, this occurs via microsomal enzyme reaction. Rest phase 2 are because of the non-microsomal enzymes. Very important 3 questions. What is phase 1? What is phase 2? What does phase 1 do? What does phase 2 do? What is the most common phase 1? What is the most common phase 2? And microsomal enzymes are involved where? Correct? So is this clear, beta? Is this clear? The phases of the metabolism have to be very, very clear. Okay, next. Question number 6. What is the effect of a drug that has high plasma protein binding? High plasma protein. Now, I told you a drug is bound to the protein. This was the drug. This is the protein. It is bound. Is it going to have a short duration? If something is bound, it cannot act. Like suppose there is a couple, right? Sometimes they do study together, but many a times the studies suffer, right? Especially of the boy, right? The short duration of action is why, because it doesn't have short duration, it has long duration. Yes, less drug interactions, no more drug interactions. Why? Because another new drug will come, N will come, it will displace it from its site, and drug interactions can be more, right? And lower volumes of distribution, yes, this is true. This is true.